Welcome to the fourth and final video in this series, Strategies for Overcoming Barriers and Improving Herpes Zoster Vaccination Rates. Let's start with physician barriers. Stefan, what are those barriers and how can we consider them?
So there's three sort of broad categories: cost and reimbursement, other more pressing health concerns on the patient so that this needs to wait for another time, storage for the vaccine and monitoring, concern about patients bringing in vaccine that's picked up at the pharmacy and whether it's still good to give. So the intervention for cost and reimbursement is to educate, to emphasize the importance of vaccine despite the potential inconvenience. That's for the physician to convince the patient, and identify online vaccine manager for direct Medicare Part D reimbursement. For the health concerns, if the patient is in and it's not an appropriate time to vaccinate them at the time of the visit, to emphasize the importance of the vaccine to prevent serious and sometimes chronic complications, and maybe move it from the doctor's office and the examining room where the doctor is to the nurse outside the doctor's office so it still can get done in the same visit if it's a problem with time in the visit. And then finally, if they can't store it or they don't have the right refrigeration resources, they can refer the patients to pharmacies or other sites where the vaccine can be administered. And that's often what we do in my office because we can't afford to keep it in the office itself.
That's exactly what we do as well.
I think the kinds of questions we can ask is, the vaccine is FDA approved for patients over the age of 50, but the ACIP recommends it for people over the age of 60. Why is that? Yeah,
this is a common question I get from a variety of physicians, and I think it's related just to the duration of protection. We know that after a certain period of time, maybe 5 years or so, that the benefits of the vaccine may start to wane, and that the best bang for the buck actually is at age 60, because the older the patient is, the more likely they are to be predisposed for zoster. So I think the vaccination at age 60 makes for the best use of the vaccine-induced immunity.
So if it's best at 60, would you still get it if you're 90? Is there an age that's too old?
There is not an age that's too old. Actually, I remember advising my mother at age 90 to get the vaccine. She was actually living at assisted living, and she was actually able to go to the pharmacy, and because she had Medicare Part D, she had no copay at all, so she received it. But to make your answer more shorter, there is no age above which you would not give the vaccine.
So I've heard about a promising new herpes zoster vaccine. Should we be waiting to give them that?
Well, there is new data concerning this vaccine, and it does look very promising. It will require 2 doses for administration. And we anticipate that there will be specific indications, but we're not sure yet. I mean, it hasn't been approved. It hasn't been evaluated by ACIP. So right now, it's still best to receive the vaccine if we see our patients who are 60 or over, or if those we want to give at age 50 or over. It's best now to use this present vaccine until we know more about how this new vaccine will be indicated and available.
So, you know, I think about that as a missed opportunity. You give them the shot when you can. You don't want to wait for something else because they may not be back or asking for it. So
that's absolutely true, and that's absolutely true, I think, of all adult vaccines. Whenever we see them for any reason in our office or in the healthcare setting, it's an opportunity to evaluate for all of these vaccines. And actually, you know, there's no reason why you can't give all of these vaccines at the same visit. I mean, the herpes zoster with their Tdap, with their influenza, with their pneumococcal vaccine, you can do that.
Yeah. But, you know, you said that the immunity wanes. So if you give them the vaccine, it's going to wane to the vaccine too. And you said after 5 years, maybe it's not so great anymore.
Yeah,
Do you give it again?
That's a good question. We do know that the vaccine, the immunity, cellular immunity wanes after receiving that booster effect from the vaccine. We do know that there seems still to be some protection, at least out to 8 to 10 years. But right now, there is no recommendation by the ACIP for a repeat dose. Now, this may change in the future. We'll see as we get more information. But right now, there is no recommendation for a second administration.
So it's natural infection, of course, is a great way to get immunity. So is shingles anything like natural infection? If I got shingles, would I then be free of having to get the vaccine?
Well, you're right. I mean, if you have an episode of shingles, which is zoster, then you will have a natural boosting of the cell-mediated immunity at that time. Now, there's some question, well, how long should you wait after you've had that booster effect? And many authorities say, well, because you have that booster effect, if you give the vaccine, you may be counterintuitive because it may reduce the effect of the vaccine because you already had sort of a higher level of the cellular immunity affected because of the actual zoster. So many say, well, let's wait 6 to 12 months to give the vaccine, but then you have to consider, again, the opportunity. I mean, if this patient is reliable, you're seeing this patient in your practice, they're going to come back in a year for other visits, well, then I think that's the best way to go.
So wait a year, perhaps,
Yeah.
at another opportunity.
Yeah, as long as you feel that they're going to come back.
Yeah, and I think another thing is with shingles, of course, that's not a new infection, that's reinfection.
Yeah, right.
It's sort of reemergence. And that also means that immunity plays in a slightly different way.
I certainly would not give it during acute zoster episode. I mean, so usually we would always wait till that acute zoster episode is resolved. But how long you wait after that, I think 6 to 12 months makes a lot of sense.
So here's a nuance I don't think you'll have an answer to, but what if they never get the rash, if they just get the neuralgia? Would that change your recommendation about a vaccine?
Yeah, that's a good point. I mean, if they never get the rash, you're going to be at hard put to make sure, or at least diagnose it, indeed that's what it was. But if they never got the rash, I would give it, because you don't know what was going on with that unless you actually did, you know, maybe a cerebral spinal fluid and looked at, you know, the ratio of the antibodies and the zoster, PCR, et cetera. But
I'll bet the patient will be itching to give you some spinal fluid.
yeah, right, right. So no, I would, in that case, I would give it.
Yeah, great. I've heard conflicting information about combining the herpes zoster and the pneumococcal vaccines. What does the CDC recommend?
Well, the CDC recommends that you can give them concomitantly together and that you don't reduce the efficacy, or at least the effectiveness of the vaccine. There is some reduction in the cell-mediated immunity that occurs after the zoster vaccine when you give them concomitantly with the polysaccharide pneumococcal vaccine. But from a protective standpoint, it doesn't seem to reduce the preventativeness of giving the two vaccines together. So the CDC is quite clear on the recommendation that you can give them at the same time.
So the slight reduction in the immunologic measures just is of a curiosity, but not of clinical importance.
Well, yeah, it does not reduce the benefit of preventing the vaccine. It's probably more than a curiosity, but less. But from the standpoint of a relevance and a practicality, it should not deter one from giving both vaccines together.
So which immunocompromised patients should get the zoster vaccine?
Yeah, I think this is a very good point as well, because we're seeing more and more of these immunocompromised patients, particularly rheumatologic and dermatologic conditions, et cetera, that are on some of these immunosuppressive therapies. But we know, at least recommendations by ACIP, that if you're on relatively low doses of this, it's okay to give the zoster vaccine. Of course, the concern is the zoster vaccine is a live vaccine. That's why we're concerned about giving it to patients who may be immunocompromised. So what the criteria is, at least as ACIP, is that if you're on prednisone less than 20 milligrams a day, or if you're on methotrexate less than 0.4 milligrams per kilogram per week, or as the thioprim less than 3 milligrams per kilogram per day, then it's safe to give the vaccines. Now, another group of patients who are somewhat immunocompromised obviously are HIV patients, and we see a lot of those patients, and we routinely would feel comfortable if the virus is suppressed and their CD4 counts above 200 to give them the vaccine.
So there are some specific strategies for improving vaccination rates. Something that we use a lot in our office is standing orders. This is where the nurses or other trained non-physician staff start a discussion about vaccines and even provide the vaccine if it's indicated. The provider can get reminders through the electronic health record. Those prompts are useful in getting vaccines done, especially annual vaccines. Zoster is different, so it's programmed a little differently. And the electronic health record is relatively new, so they may not yet know if they've gotten a vaccine before, but it's a start. So patient reminders using postcalls, letters, and phone calls are a strategy that's used for flu vaccine, and you can stick a Zoster recommendation in those reminders if your office is using them. Organizational, staff, and procedural changes. So you can run vaccine-only clinics, designation of a specific person in your office setting that, or a nurse or another healthcare staff to provide the vaccines as their primary job to also get the quality numbers up.
Well, now let's address patient questions and concerns. So let me ask you some questions, Stefan, about these. And the question here is, I already had the shingles. Doesn't that mean I'm immune to having it again?
Yeah, so we've touched on this already. Having shingles does increase your immunity some. It doesn't last very long, and so know you can still get a recurrent shingles episode, and the risk of recurrent shingles or zoster is about 6% for the general population and 12% for the immune-compromised population.
Right, and as we said, we might want to wait 6 to 12 months if the patient's reliable coming back. Okay, another question. I've never had chickenpox, so why would I need a shingles vaccine?
Yeah, so for the population that's over the age of 40, close to 100% have had chickenpox whether they knew it or not. So I think with some certainty, you can tell patients that they are likely to have had chickenpox and they are at risk for shingles. Another thing that you can look at is if they haven't had chickenpox ever, their risk for having severe chickenpox goes up with age. So if they're under the age of 40, you might want to think about getting them the primary vaccine for chickenpox, and then think about when you might give the zoster vaccine later on.
Yeah, but we don't have to evaluate the patient with a blood test to see if they have had varicella or chickenpox in the past, right? I mean, we can just go ahead and give it.
Yeah.
Yeah, so we don't have to, okay. Another question. I have a family member who is on chemotherapy. Can she catch the shingles virus from me after I'm vaccinated?
Zoster vaccine virus is an attenuated virus. So it's not easy to transmit that virus into an immune-compromised patient from a person who's had the vaccine. It is transmissible at a very low level, and I think simply covering the area if there's lesions after the vaccine is sufficient to protect the people in the household.
Yeah, I guess we should mention that it's possible to have slight amount of shingles or zoster vesicles, but just a few minimal number associated with the injection site, but actually that's not very common at all. Now, what about the issue of needle phobia? We mentioned that one of the other videos. What's the issue with that?
Well, there are a substantial portion of patients, maybe as many as a quarter, who are afraid of needles or the pain from a needle. And I think there's a three-step strategy that folks can employ to reduce anxiety. That's sort of, first of all, recognizing that they have this phobia and helping them relax, control, and prepare them for this. What I typically do is I'll tell you, you know, this isn't going to hurt more than a pinch. Here, let me pinch you so you can feel how it's going to feel, and I'll tell you right before I give it, and then I pinch them, and then right after the pinch, I actually do that, insert the needle. Graded exposure. Physical interventions to reduce pain is topical local anesthetic. I haven't actually done that.
No, I haven't either.
Heat or cold or pressure prior to the injection, and my form of pressure is a pinch, which is more than just pressure. Visualization and distraction, and I sometimes do that. I put them in a happy place before I scare them with a needle.
No, I like your process about the little pinch. That's a good idea. I'm going to have to do that when patients complain about getting a needle. Well, let's address issues related to costs. We've mentioned this in some of the other videos, but for patients who have Medicare or private insurance, we need to explain to them there may be some co-pays that apply, but we need to educate them that definitely the cost benefit is there to prevent vaccine by giving this, giving the vaccine. And then for patients with Medicaid, but no coverage, or patients who lack insurance, there actually are vaccine assistant programs that you or your staff can utilize to administer the vaccine to the patient. And I want to mention again about the importance of how we actually recommend the vaccine to our patients. There are many studies to show that if we strongly recommend the vaccine to our patients, I mean, the patients will be motivated more than by listening to celebrities on TV or the anti-vaccine movement or whatever. So they have a lot of confidence in us if indeed they are our patients. So it's really important how we provide the message. So don't use on the top part of the slide, which is more passive or ambiguous, such as, do you want the vaccine, or think about the vaccine. It's like we mentioned in the other video, this is something that they should receive. And so we should say, you need to get the vaccine. I want you to get the vaccine. It is time to get your vaccine right now, and we're going to schedule it. And that makes a big difference as to patients accepting the vaccine.
So here we can see a slide of the impact of provider recommendations on vaccination. And you can see that when there is a strong recommendation, the majority of patients end up getting the vaccine. When there is no strong provider recommendation, that's the right two bars, there's very low uptake of vaccine. So that strong recommendation, today is the day you need to get your vaccine. Here I have your vaccine for you. You should be getting your vaccine. Go to the pharmacy and get it today, are the kinds of recommendations you want to put forward to get them to do this. Short of that, you will have failed your patient in getting this important protection.
Now, there are going to be many patients, even when we give a strong recommendation, are still ambivalent. I mean, so there are other strategies that we can use. And this is an acronym. This is the SHARE concept developed by the National Foundation for Infectious Diseases, which is a way to communicate with patients about vaccines. And I'll just go quickly through this. S is just to share individualized reasons why the vaccine is right for the patient, and also to prevent the complications that may occur from zoster. H is to highlight the positive experience with vaccines. A is to address patient questions. It's really important to address that. We usually give the vaccine information sheets, which is available from CDC, which explains the rationale why the patient should get the vaccine. And it's very transparent, not biased at all, because it also gives them recommendations, or at least advises them about possible adverse events and where they can communicate with if they have any significant vaccine problems. R is to remind the patients that the vaccines protect them and their family. We mentioned that. And E is to explain the potential cost of contracting a vaccine-preventable disease. So all of these can be very helpful in motivating patients to receive the vaccine. Now, there's another process, this motivational interviewing process. It's been around for several decades, but it's interesting, at least our medical school now is starting to adopt it and promote it for our medical students in interviewing patients. But it's a process by which, sort of in an unbiased way, in our dialogue with patients, we encourage them, the patient, to become self-motivated to receive the vaccine, or actually change any health behavior, such as stopping smoking or reducing weight or whatever. And it uses this ORS technique, which is another acronym, and O is for open-ended questions, A is for affirmation, in other words, affirming that they want to be healthy. I mean, people want to be healthy, and so we have to reinforce that. And then reflective, just reflecting on what could be the issues if they don't receive the vaccine, and then a summarize of all these considerations.
So some shortcomings of vaccine education that we mentioned in the prior video include not being able to address the patient in their learning style. So for example, the denialist will be somebody who refutes any data you put before them. And I think one of our challenges, so I get those patients, is there's nothing you can do to convince me. We hear it in this, in our political environment, you can't use an intellectual argument to change somebody's mind about something. And the approach that you use here for patients is, for a denialist, is something where motivational interviewing actually could make a difference. You reach them in something that makes them actually not think about the data so much, but think about the WIFM, what's in it for them, and ask them about what they see for themselves as a healthy person, and then reflect on what they think they need to do to get there, And then I think ask about, well, what about, you have a 1 in 3 chance of getting shingles in your lifetime, and in your patients that have now made it to 80, a 50-50 chance. I think you can gradually change how you argue about, and I use the word argue, I would, I think, preferably say present, how you offer the opportunities to the patient, because now it becomes an opportunity rather than a demand by the physician. Now, this is a little counterintuitive because we're supposed to be giving strong recommendations, but we have a denialist, and we're now trying to work it both ways.
Right, and I think your point about arguing is counterintuitive to the motivational interviewing process as well. But what I always like to do is, and you mentioned, a third of the patients are going to get vaccine, are going to get zoster. And so these patients probably know somebody, either in their family or friends, who have had zoster. And what was that like? And wouldn't you want to prevent that? So I think these types of processes and reflective discussions can help patients be motivated or self-motivated to receive these vaccines.
Yeah. So second style is for the individuals that are innumerate. And what that means is they don't have health numeracy. They can't work with numbers. So you can say, you have a 30% chance of getting shingles or zoster. And they don't know really what 30% means. They can't grasp it. And one of the strategies I use for that is, for example, I say, do you buy car insurance? Well, why do you get that? What's your chance of getting into a serious accident? And so it's a way to approach that. Fear-based, they might say, I've heard that the vaccine is harmful, and I'm not going to get it for that. And so with this, you want to understand sort of what exactly they're afraid of. And that could be anything from the needle to other things, side effects and so forth. And again, comparing this risk to other daily risks that they incur, like stepping into an automobile or stepping off the curb for my 90-year-olds, are all things that I think one can use. Social norming is part of this also. The heuristic is one of the challenges we have. And a heuristic thing is something I get frequently. The example would be, I remember that Guillain-Barré happened in 1977 when they were giving out flu shots. That must be common. I wonder what's going to happen with this vaccine, or therefore I'm not getting the flu vaccine. So this shortcut in applying some remote piece of knowledge to something that is present in the current situation may not be scientifically accurate, but it might actually play into how they're making their decision. So stepping around the heuristic and pointing out that we have better data, if they're able to work with that better data, if they're not denialist or one of the other ones, I think is an approach. Bandwagoning is where they follow what they think everybody else is doing. So when I'm making my strong recommendation and they give pushback, I will usually throw that in. I said, well, all of my other patients today have been getting it. And it's your chance, to get yours too. So there are strategies that we can use in this context. And then analytical, somebody where you just can't give them enough data, and they want more data to substantiate that. And I don't know which ones you have that are most common.
Well, I would say the ones that are most common in my practice are the denialists, that just don't feel that they need it or whatever. And we have to explain to them that they are in a group of population, depending upon their age, that they are going to be at risk, and looking at the benefit of getting this vaccine to prevent it and the complications that can occur. Because I think, if anybody has known anybody with postherpetic neuralgia, they want to avoid that. That can be so debilitating, as we've talked about in these other videos. That can be a compelling argument to try to prevent that type of complication.
Yeah, it's hard. It's like the smoker who quits after their heart attack.
Oh, that's true. Yeah, that's true. I can't tell you how many times I was rounding just yesterday in the hospital seeing a patient with pneumonia. Of course, the standard question, do you smoke? No. When did you quit? Yesterday. That's the type of thing, when they were admitted. So that's an important issue.
Yeah, so I encourage them not to wait until they get their shingles to decide to get their vaccine.
Right, right. Very good. Well, Stefan, do you believe that the anti-vaccine movement affects the herpes zoster vaccine rate?
Yeah, I haven't seen it that much yet with zoster, but certainly with other vaccines. And I think we need to be prepared for it. We don't have enough information yet to and the vaccine isn't used enough yet, I think, for it to have caught traction. But as its uptake increases, I think it'll get traction and it'll get in the crosshairs of the anti-vaccine movement. We have to do things to be ready to respond to those when they come, and that includes, for example, funding and publishing high-quality studies to investigate the concerns about vaccine safety as a good starting point. We have to have monitoring programs. Currently, we have a vaccine adverse event reporting system, which I think is a good place to start, but I think folks need to report. And the backside of that is we're only reporting when bad things happen. I think
Correct.
there needs to be information about how little is actually happening, that the bad events are in fact pretty rare events.
And we have to balance that, you know, on the other side with the burden of the disease and the burden of the complications. And so, you know, when you consider what the adverse events are related to the potential complications that we can prevent, it really weighs it on the part of receiving the vaccine.
Yeah, and I think there's some craftiness in how we do the messaging, because we don't want to over-alarm people that the rare complications are frequent, like heart attacks and stroke. But at the same time, the rare complications do occur, and there's some really important complications like post-herpetic neuralgia that are not at all infrequent, that can be substantially attenuated or prevented.
Yeah, right, correct.